Okay, so last summer I was on vacation, Botswana if you care to ask, and I got an email on August 4, 2018. It kind of rocked my world. So this email, I opened up, now why was I checking my email? I don't know, it's obsessive quality. I opened it up and it's from Greg Stone. And Greg says, "Dear COAPT co-author, on behalf of Mike Mack, Bill Abraham, Joanne Lindenfeld, and Abbott, it is more than a pleasure to finally send you the COAPT manuscript. As you read this, you will immediately realize the huge impact of this study. It is essential that you keep this confidential. Therefore, please do not tell or even hint to your spouse, family, partners, or anyone else so as not to jeopardize the presentation." I have to admit, I did tell my wife, she's a dermatologist, and even she was impressed because when you look at the data, it is almost all about COAPT. This has really rocked the rest of the world. It's pretty simple why this is. Look at these data to remind you. Remember, 614 patients were enrolled in this trial. 302 were randomized to CLIP, functional mitral regurgitation. So they had mitral regurgitation secondary to heart failure. They were randomized to control or to device. And the rate of hospitalizations at 2 years was 35.8% for the device arm versus 67.9% for those who just got medical therapy. And death, this is, I want to emphasize this, death from any cause within 24 months occurred in 29.1% of patients in the device group as opposed to 46.1%. That's an absolute reduction of 17%. So, this is TAVR-like mortality reduction. It was absolutely stunning. And it was funny when I was asked to give this talk, I thought I would just show these two slides and just sort of walk away, because what else is there really to say? Well, it's interesting because there is still some debate about this, and that is, yes, COAPT was very positive, but MITRA-FR, which was a smaller trial, was not. MITRA-FR was also a trial of patients with functional MR, a smaller number. They had ejection fractions of 33%, similar to COAPT. They had a little bit less MR, and they had larger hearts than patients with COAPT. Their mean effective regurgitant area, that is the amount of, sort of the regurgitant orifice of the jet, was 0.31 compared to 0.41 in COAPT. Bigger hearts, their left ventricular volumes were 250 cc's compared to 192 in COAPT. And at 1 year, there was no effect on the risk of death or hospitalization for heart failure. It was amazing to me, and I think Chris was there at EuroPCR. I was looking at that there was this debate about after MITRA-FR and COAPT whether or not MitraClip is actually a useful thing in functional MR, and the protagonist of that was the senior author of the MITRA-FR study. He said, based on MITRA-FR, I don't care what COAPT says, the data are still not totally there in telling us. And so the question is there an explanation? Now, Saibal Kar told me what the explanation is. He said, well, COAPT was an awesome trial and MITRA-FR was a shit trial. Now, I think that is perhaps a bit unkind, because the reality is there some kind of thing that we can glean from both studies to better understand how to select patients for MitraClip and to understand who's going to benefit, who's not? Because certainly we know in COAPT there were patients that did not necessarily improve with CLIP. As a population, yes. What is the truth? What is the truth that is in the middle? And what's come up is a very interesting concept. Any echocardiographers in the room? Okay, so I can mostly BS, except you're going to call me out if I say something that doesn't make sense. There is the question, and this is really a brilliant thing that Paul Grayburn and Milton Packer have come up with, to say that, look, you can have functional MR, but not all functional MR is the same. Maybe it's more the ventricle in this case. Maybe it's more the MR in this case. And maybe this might explain the different results that we see and that perhaps we'll continue to see, either with MitraClip or other devices. So these are some cartoons I drew. So heart on the left is small, heart on the right is big. Let's assume that the ejection fraction is 30% in each of these cases. So, and let's assume that this is the volume. So if ejection fraction is 30%, then obviously 30% of that volume is being pushed, is being contracted out. So up the left, that's about 63 cc's. On the right, 80 cc's, right? The same ejection fraction, the same, quote, pumping function, but because the heart on the right has a lot more blood coming in, the stroke volume is a lot higher. Now let's assume that you look on echo and you see the exact degree of mitral regurgitation, severe. So, you know, in 0.3 or higher, I think in functional MR, we agree that we're in the severe range, 0.4 definitely. And so based on this, you can say that in both of these hearts, severe MR, regurgitant volume, if you calculate, the amount of blood that's going the wrong way is, let's just say 36 cc's. And what ends up happening is your regurgitant fraction, that is the amount of blood that is coming into the heart, what percentage is going the wrong way, is different between those two. And what Paul Grayburn and Milton Packer are arguing is that this could potentially explain the differences between these two trials, that both of those could be right in their own way, and it could help us potentially as a community learn how to better select patients. Now, you know, I think they're doing a very reasonable and responsible thing by saying, look, this is just a framework. We cannot make clinical decisions based on this, but it's something for all of us to start thinking about because we're going to be treating lots and lots more of these patients. So what does this mean? Now, this is where this whole thing is going to slow down because these videos are very large. Okay. This is what they're talking about. They drew this line, and they said, you know, like 50%, so, you know, that line represents 50% regurgitant volume, which means of the blood coming in, 50% is going the wrong way. And if you go up top, it's a lot more than 50. If you go below, it's a lot less than 50. And if you look at the population of MITRA-FR, guess what? They were down there, which was, quote, proportionate MR. And up top in COAPT, this was disproportionate MR, meaning there's more MR than you would really expect based on how big the hearts were. And there was a difference in benefit. So here's an example. This is an 83-year-old man, ischemic cardiomyopathy. I'm somewhat embarrassed to show this because he would be excluded big league from either COAPT or MITRA-FR. I mean, if you look at his end diastolic volume, remember MITRA-FR is 250. And COAPT was 190. He is way out of bounds, okay? But we've maximized his medical therapy. We've looked at advanced therapy. He's 83. He's not a good LVAD candidate. We've looked at everything. We said, you know what? We're going to just do the best that we can. And here's his echo. I mean, this LV is like this big, and it's not moving. And you can see how much volume there is at rest. And the MR, you know, it's posteriorly directed because of posterior leaflet restriction. You can see the apical tethering. This is classic that goes along with functional MR. You can look at other measures, the EROA of 0.3 or the 3D at 0.46, clearly severe. The pulmonary veins are reversed. Everything is going along with severe. But if you look at that, you would say, well, we're not sure if this person is necessarily going to benefit. Just based on, honestly, just how big the left ventricle is, independently of whether or not this MR is proportionate or disproportionate. So, you know, we go ahead and we using interprocedural TE, which is the standard for clipping. We go in, we can see some beautiful surgeon's views. Clip is aligned. There's really nothing special about this procedure. We just go down the barrel, clip the leaflets, and I think at the end have a pretty reasonable result. Actually put in 2 clips. I would say really mild MR. And pulmonary vein flow is actually normalized, and the gradient is reasonable. What's interesting is at 1 month follow-up, there is some reduction in left ventricular endostolic volume, so he's having some remodeling. The ejection fraction is lower, and the stroke volume actually is significantly lower. So we did something, I'm not sure what we did. Now, and in 1 month, everything is improved. The up top is before, down is after. Another view of that, you can see the classic bow tie figure of MitraClip there. Patient feels better. This is awesome. Patient also dies 7 months later from congestive heart failure. And you know, you always hate to get these calls because, you know, you say, hey, do you remember Mr. Jones? You did a MitraClip. Oh yeah, he was looking great at 1 month follow-up. Well, you know, he kind of came in and crashed and burned, or he died at home. And it always causes you to just pause a minute and say, did we do any good? And did we really follow him as well as we should have followed him. Here's a different patient, 62-year-old woman. Her left ventricular is almost half as that gentleman I spoke to you about. This is someone that would be enrolled in COAPT. And you can see the ventricle is you know, a lot smaller, ejection fraction is around 40. Next slide is going to show you the MR, same thing. Kind of apical tethering, a little bit more restriction of the posterior leaflet resulting in a posteriorly directed jet. All the other parameters are coming up with severe. And if you look at this, what's interesting is these patients, all the parameters are following up more of a COAPT-like population. And so we go ahead and clip her. This is the pre-procedure TE. Nothing special about this. Just aligning the clip a little bit more with this. And what ends up happening is she has a very good result. She has a COAPT-like clinical outcome. She's no longer hospitalized. Her NYHA class goes from 3 to maybe 1 on a good day. And there's the classic bow tie. Ejection fraction stays about the same. We have reverse remodeling. And 1 year, she's alive at 1 year. She comes back in 1 year, and she's doing very, very well. If this pauses, then, oh, there we go. So I think this is an interesting concept, and I want to emphasize this is a concept. This is not to make clinical decisions. This is to say maybe we need to understand this field a little bit more as we keep doing more MitraClip or functional MR, as we look at transcatheter mitral valve replacements. But the question is the benefit of MitraClip different depending on whether you have proportionate or disproportionate MR? Maybe, maybe. Now, what I have to say, I got a little angry when I saw this diagram in circulation, because it was a step a little bit too far that I think Dr. Packer took. And what he said is, he said, look, if you look at all the trials, you find an interesting pattern. Those patients with proportional MR, they don't tend to improve with device therapy, ring angioplasty, CRT, transcatheter. They have neurohormonal modulation. This is contractility modification. It's that funky device that sends impulses during the refractory period, or LVAD. And then they say, well, but if you have disproportionate MR, you probably really benefit from device therapy. The reason I modified this slide myself is, remember in COAPT, every single subgroup benefited, even those that had lower ejection fractions or higher end diastolic volumes. So, you know, we get on trialists, over-enthusiastic, overzealous trialists who have a negative trial, and then they start parsing out subgroups and saying, oh, look, it's positive in this group. Well, conversely, we should say the same thing. We have a positive trial. I think it's difficult to kind of, after the fact, concoct subgroups and say, well, we don't think they're going to benefit. We don't, in order to test that scientifically, you would have to take proportionate MR patients and run a trial like COAPT, as well as it was done, and randomize them to medical therapy. And so what is my conclusion? I think this is a very interesting framework, and it can inform us about perhaps how much patients can benefit. And these are my take-homes. Let's not be too hasty, because again, this is coming from someone who clips a lot. But nonetheless, every subgroup in COAPT, lower EF, higher left ventricular end diastolic volume, benefited, including a MITRA-FR-like subgroup. At EuroPCR, what they did is they actually looked at patients who had ejection fractions, low ejection fractions, and high end diastolic volumes. I think it was 96 mLs per meter squared. They said there was no benefit, but the confidence interval is very wide. I don't think you can say that. So what I'm saying is, if you have patients that fit COAPT criteria, I don't think you should deny them, and they're optimized and they have resynchronization, you should not deny them clipping based on whether they have proportionate or disproportionate MR. But what you can say is maybe the magnitude of benefit for MitraClip is less if you have such a patient. And maybe you need a little more vigilant follow-up, because if you have enormous left ventricles, maybe you should see him before 7 months. You should see him at 3 months. Maybe you need to think about advanced therapies sooner rather than later. Now, the most intriguing thing to me is, right now, MitraClip is the safest transcatheter mitral valve therapy and proven to be effective, full stop. Every single transcatheter mitral valve replacement, as exciting as they are, I don't know that they have the same risk-benefit ratio this early on. And so it's possible that in the future, if you have devices that are more efficacious at reducing MR, but their risk is perhaps a little bit higher, if we have more data, we might say to ourselves a disproportionate or proportionate MR patient might be steered towards the safest, least invasive therapy, i.e. clip, versus disproportionate, where we'll have a little more equipoise if those devices actually come to fruition and show safety and efficacy. So it's interesting. The journey that, at least for me, began 6, 7 years ago and culminated with that email and then the subsequent publication. But I think that journey is going to continue, and we're all going to learn from. And I am grateful to Dr. Packer and Grayburn for raising this, because it's interesting to take data and say, okay, now we've got some great starting points. Let's see how we can further the field and maybe even improve selection and benefit for patients so that we can all benefit. Thank you.